some of our patients or viewers that I have found on Instagram, TikTok, Facebook, YouTube. So the first question is it really bad that I still have my implants in? They deflated in 2013.
So good morning, warm welcome to everyone, and please feel free to ask any questions. You can go to the comment section and please go ahead and ask any questions so that I can help you understand how I view what is a true problem, a true entity, what is breast implant illness and how to deal with it, and these very real life questions, and hopefully you will be able to understand breast implants as I do, given my practice. So if someone has a ruptured implant, it is not normal or healthy to have them be inside the body, be it a ruptured silicone implant or be it a ruptured saline implant. The silicone is present within both. Saline implants cause the same hurt as silicone implants, and intact silicone implants and ruptured silicone implants. So all three are in the same category. So if a patient comes to me with complaints of problems related to the breast implants, you will see patients with saline implants, ruptured saline implants, intact saline implants, intact silicone implants, and ruptured silicone implants are interchangeable complaints. I cannot gauge the severity of the problems that these patients are going to have depending on what type of implant that they have and what is the nature of the implant. Clearly, as you can see, it is not normal or healthy to have a ruptured silicone implant. That's why if you look at the mentor recommendations, this is the mentor advertisement up at the top. At the bottom it says here, MRI screenings are recommended 3 years after initial implant surgery and then every 2 years after to detect silent rupture. Silent rupture means that the exam is unremarkable, it's normal, and the patient has a ruptured implant. So it is not healthy, not smart, and not wise to keep something in that is not doing its purpose or its role. And it is only smart to not only remove the implant in itself, be it ruptured or not, but to remove that capsular burden around and that inflammatory tissue into which that silicone gel bleed has occurred, so that all of the badness is removed with only good, healthy, viable tissue remaining behind. We know that the silica basically in patients, some small set of patients, does migrate into the neighboring tissue and into the periphery. We know this if you look at the guidelines over here. Breast implants, certain labeling recommendations to improve patient communication, guidance for industry and Food and Drug Administration staff. And this was issued on October 24, 2019, you will see that this is on page 14 at the top. It says here, I understand that silicone can migrate from an implant into nearby tissues, for example, chest wall, lymph nodes, under the arm, and organs, liver, lungs, where it may not be possible to remove. I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer. Mammography can also cause the breast implants to rupture or leak. And the other thing is, I understand that all breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of this implant, but small quantities have been found to diffuse gel bleed through the implant shell of the silicone gel-filled implants, even if the implant is intact and not ruptured or leaking. And the heavy metals that are listed, as you have heard me say before, are these heavy metals found in breast implants: arsenic, barium, beryllium, cadmium, chromium, cobalt, copper, lead, magnesium, mercury, nickel, platinum, selenium, silver, tin, titanium, vanadium, and zinc. So going back to the question, which is a very legit question, not healthy, not smart to leave something behind that may cause a lot more hurt than people imagine. Not smart and wise. If it is broke, remove it. Next question, please.
After explant, what is the process to refine the breast tissue that is left behind?
So this is a very good question. a patient may come in with a ruptured implant, so that might be a lot more inflamed tissue than the other side where there's a normal implant. One may bottom down malposition, another one may get capsular contracture grade 4, the other one might be grade 1. Another patient might have radiation on one side, for example, so that tissue that remains is going to be very different from the effect of the radiation. Another patient may have had a bacterial contamination, colonization, and a different result, or the surgeon technique might have been different on one side versus on the other because the patient ended up getting a lift and an implant on one and no lift on the other because she had hypomastia, no breast tissue on that one other side. A lot of it is dependent on the surgeon, the previous initial surgeon's technique that is also critical into what the long-term effect is going to be, if it is below the muscle or above the muscle. So there's so many variations that the patients have to begin with, given the technical proficiency of the initial surgeon, the aftermath of having the implant in the body. Now remember, the other thing I want to mention here is this: if you go to the black box warning, that is, we all know this, you can Google this. It says over here, breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery. So on one side may be an intact implant, other side may be ruptured. I, as a plastic surgeon, when I remove the implants, I make the cut, and as soon as I go in, I identify the capsule, and then I ride the capsule millimeter by millimeter as I dissect, such that I do not touch the breast tissue. So in the vast majority of the cases where the implants are below the muscle, if this is the muscle, if you will, I'm always operating below the muscle. I do not make cuts into and around or up into the muscle. I do not cut around the nipple areola. I do not touch the breast tissue. If the breast tissue is above the muscle, which is in the majority of the cases when the implant is below, I always remain below. So I remove that capsule and implant and all of that inflamed tissue underneath the muscle, not touching the breast tissue. That's why I've operated on many patients who are actively nursing, breastfeeding their children, or if they're pumping, because this is P1, if you will, irrelevant, have nothing to do with the breast tissue. I'm always below, and this is where I remove the entire implant capsule. And then what I do is I remove what is that excess skin on the side where the implant was working as a tissue expander, and I put a dot at the nipple on the right and left breast, and then I measure the distance from the nipple down to the crease such that it is, let's say, 7 centimeters on right, 7 centimeters on the left, and now I can cut more skin on one side versus less skin on the other, so that I can now make them more symmetric, if you will. As you will see, this is a very direct way to make the two sides symmetric. Now remember, on a given patient, even before an augmentation, no two breasts are the same to begin with, no two sides of the face. If you draw a line halfway right in the middle, my right side of the face does not match the left side, and this is true for every patient who one part of the body does not, and specifically the breast tissue as well. But this is my time as a surgeon, as a board certified plastic surgeon, to match the two such that they will be symmetric. I have cut a lot more tissue on one side if the patient had more breast tissue on one side versus the other, so as to match and balance and equal them out. And so this has been one way of doing it. The other thing I want to mention here is this. One patient had her surgery done in Argentina above the muscle, and both of them were ruptured implants, and it was, if you will, like a mini explosion inside the breast tissue, and the silicone had extravasated and spread into the periphery, into the breast tissue, and now there was silicone granuloma within the breast tissue. Now my task was to remove all of the implant capsule and that ruptured silicone and the silicone granuloma, and believe it or not, it had made it to the level of the skin on the left side, such that it was abutting very close to the skin. Now my goal is to remove all the badness, all the silicone granuloma, all these masses. And so inevitably I was very close to the skin, and her damage was a result of the explosion, if you will, that significant severe inflammation that was present as a result of the free floating silicone on her left breast. This is very similar to someone gets a bad burn onto the arm, and gets a grade 3 burn, grade 2 burn, and it is a significant trauma. Post-op, the surgeon puts everything together. It will never look like the left side, and this is the aftermath of the significant inflammation that the patient has had. Now, this is, very well established in the medical literature as well. So this is now page 15 of that same, it says, quote, "I understand that breast augmentation may result in permanent changes to my breast tissue, and if my implants are ever removed, I may be left with unsatisfactory appearance, changes to the size and shape of my breast, including but not limited to dimpling, chest wall concavity, puckering, sagging, or different incision size or location. If I am an augmentation patient, any additional surgeries or medical procedures will likely be at my own expense." So going back to, and they want you to, on the next page, they want you to initialize that, patient initials, that the surgeon has basically discussed this with you. Now, remember, as plastic surgeons, we deal with a lot of reconstruction, patients with burns, trauma, breast cancer. Our job is to work with the many patients who come in with many different traumas to the chest, sometimes even caused by the surgeon, him or herself, if you will. So those patients that have had the incision around the nipple areola, I myself, as a plastic surgeon, board certified, in my practice, I say this is a horrible idea because you're cutting the nerves, the ducts of the nipple areola. You're putting a scar in the center of the breast. You're basically then cutting through the whole breast tissue to put the implant below the muscle or above. And now as the surgeon comes out, they're suturing close that entire breast area. And as you will see, some patients have had altered nipple sensation. They have had scar tissue, painful scars, puckering, indentation of that incision. There is cut through the breast tissue. Now it shows up on a self-monthly breast exam or a mammogram, and now you have these irregularities that show up on the breast, all because of the surgeons. I use the word poor choice, if you ask me. And I can critique how the surgeons are doing it, just like they can critique what I'm doing. And the point I'm trying to make here is that look at the trauma that was caused by doing that alone. Sometimes there are bacteria that are harboring within those ducts, if you will, and they can be potentially involved as far as the trauma as a result of the surgery in itself. Now, I myself am left with those patients post-op, where once I remove the implant, now all of a sudden that incision and the nipple areola complex cinches in, and the patient's unhappy. And I said, well, this is the aftermath of what your previous surgeon did. Now, I have seen with cupping, even in those rare cases, for example, you cut out the scar and you put sutures in, you can address this later on. Remember, the goal of this surgery is to remove the entire implant capsule, all inflamed tissue, completely, sincerely, honestly, and at the same time, put out what is a symmetric, nice result. And there is a lot that I can do on one side versus the other, such that I can balance them out. And then, if needs be, later on at another stage operation, after the patient has settled, maybe 6 months, a year later, other interventions can be done so as to allow for normalization of the two sides. Fat transfer, horrible idea. What I use the word malpractice, bad medicine. Some of the fat will inevitably die and form clumps of dead fat that may get picked up on a self-monthly breast exam or on a mammogram. And now you're going to be in an anxious state or doing serial repetitive mammograms every 6 months or a year, potentially concerned about if this is breast cancer or not. Remember, 1 out of 8 or 9 women will get breast cancer. And you do not want to be altering a state of the breast such that now you are getting unnecessary anxiety or unnecessary procedures, even biopsies, just to rule out malignancy. I have had patients that came to me from world-renowned plastic surgeons where there were masses sitting in and around the breast tissue where there was concern for malignancy, and the breast surgeon did not want to biopsy it because they were concerned they were going to damage the implant. And so the patients came just wanting to explant for that reason, so they could get a representative biopsy of that mass. So overall, if you have to look at the pros and cons, risk versus benefits of any procedure, and certainly this one, And one needs to understand what are the implications of getting an implant. Anytime any surgery is done in any part of the body, be it the hand, be it the head, be it the belly, and certainly in the case of the breast, scar tissue inevitably remains, and that adhesion can cause indentations, irregularities, among others. In summary, and I'll end with this for this question, I do not touch the breast tissue above the muscle. I do not cut up and down from the nipple down. I do not cut around the nipple areola. I only make that horizontal cut in the crease, an incision that hides in the crease that gives me excellent, perfect access to the rib cage so that I can dissect parallel, and an incision that allows for me to dissect safely, completely, definitively, wholeheartedly, all the way up into the upper part of the chest, so that all of that capsular burden and implant and inflamed tissue is removed below the muscle without touching the breast tissue above.
I had my implants removed, but now I feel like I am disfigured. I know I shouldn't get implants put back in, but is it possible to do that after explant?
So after explant, you can do and balance the tissue out once they have normalized, once the scarring, the wound has settled. And you can certainly go to a plastic surgeon who can basically remove any tissue more on one side if there is any puckering or indentation, such that you can address any problem. So let me go ahead and address this. Let's say if a patient had a small chest, according to the guidelines, if someone is augmenting, you look at the chest width, let's say it's 8 centimeters. You will then go to the catalog and get something a little bit smaller, 7.5, 7.8, and then put the implant that would be appropriate size for the patient. You do not want to put like a 600 cc implant and the patient deserves 300. Now you're cutting not towards the midline, not towards the lateral, because you don't want the implant to fall, but you're cutting lower, and now you disturb and cut through that inframammary crease ligament that now allows for the breast tissue and the anatomy to change, quote unquote, if you will, for the worse. Now, once the implant is removed, you will see there's a lot more redundant skin. The incision is relatively lower, and now you have that outpouching of that skin. That certainly can be cut out at a later time once the wound settles, if that makes sense. And so the bottom line is there's a lot that the plastic surgeon can do. Remember, we are very creative surgeons. Our goal is to achieve symmetry, but at the same time, if there is ever a time where the end result is not optimal, do not settle for less. I tell my patients, do not settle for less. Do it right, do it once, do it definitively without overdoing the surgery. That's why I do not offer a lift to every patient. I saw a 70-year-old patient I operated on 6 weeks ago, and she had 350 cc implants, and you will hear from her own words, her surgeon was an excellent surgeon, very reasonable size implants for her height and width. When I removed the implant, she clearly, despite her being postmenopausal and the length of time that she had the implants, well over 20 years, and her age clearly was not a candidate for a lift. She had already gone to another plastic surgeon who said, absolutely, you need a lift and you need a fat grafting because you are 70 and you have had these implants all these years. And she knew better that she was not going to do a lot at the initial time of the explant, where just the 4 hours are allocated for explant. You do not want to be doing something that you may not need and that ultimately may end up only harming you.
How long do I have to stay after surgery to have the drains taken out?
So first and foremost, the last time I even used the drains was well over 5.5 years ago. So you are not going to be getting the drains. The 7 times that I've used the drains are in those patients where as soon as I made the cut, there was free-floating silicone, like that 81-year-old patient who was involved in a car accident, and she had free-floating silicone in her chest, worked up by the trauma surgeon. As soon as I made the cut, there was silicone literally pouring out. So she bought herself the drain because that was unavoidable. Another patient with trauma to the chest, where she got a kick on her left breast, and now the implant had ruptured and she was in acute pain and she knew something was up and she wanted surgery. But the next day, as soon as I made the cut, there was free floating silicone. So in those patients, the determination was already made. In my practice, I removed the entire implant capsule and all inflamed tissue. and I removed the entire capsule by removing the fascia of the intercostal muscle, fascia of the serratus, which is the layer directly on top of the intercostal muscle and the serratus anterior and the pectoralis minor. So there is no chance that the capsule is left behind. There is no silicone spillage. All of the bad tissue is removed, and clearly the blood loss is less than 99.7% of the time, less than 5 cc's. So the drain requirement is not there. My patients have not posted on Facebook that I needed a drain or they had to go and get a drain at another local hospital. None of the patients say this. And this is a surgery where I even presented at an international conference in Dubai that the patients do not need drains if the surgery is done right. And this is where very painstaking, very carefully, very meticulously, the entire capsule is removed millimeter by millimeter, leaving behind only good, healthy, viable, precious volume and tissue, and removing only the bad. And this surgery absolutely can be done very safely without drains. And as you will see, many of the surgeons are now attempting to do the surgery without drains. And if a surgeon is not using drains, that gives me that confidence that the surgeon did the right surgery. If any of the silicone spills in the chest, or the capsule is cauterized and burned but not removed, which is wrong, or if there is any bad tissue left behind, or if the surgeon removed the capsule implant from below and the capsule from upper part of the chest was not removed, or if the surgeon removed the implant capsule below the muscle but did not remove that residual capsule from when her first set was put above, now the drain becomes mandatory, and it tells me kind of very directly that the surgeon did not remove all the badness, and now the drains become mandatory, or the surgeon is rushing through the surgery. Conversely, the drains themselves, if the bulb syringe opens up, backtrack that fluid and end up into the chest, and that will be a major catastrophe, because remember, that is not sterile fluid, it's dirty fluid with bacteria. Or if the tube goes in and out, it can seed bacteria into the chest, which can be a catastrophe. So the drains themselves are not safe. So you have to do your homework, you have to do it with good analysis, that the placement of drains is not there. It is when the surgery is done correctly. And this is me having done literally thousands of these explants without the need for drains.
Why do many plastic surgeons deny that breast implants are a problem and that they should not be put in?
So unfortunately, this is the reality of the situation. If you don't accept a problem, you don't have to deal with the problem. Sometimes we, as in human nature, we do not want to even look at the problem, so we don't even have to answer the question. I have had so many of my colleagues, my friends, say they do not believe in breast implants. Well, guess what? First and foremost, this is like 1 + 1 is 2. If you look at the same mentor advertisement right here, up at the top, they're advertising. This is the back of the journal that we read. I copied it and put a lamination on it so I can show. And this is part of the black box warning as well. You can Google this, and it says, quote unquote, patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. I'm going to stop here. This automatically means breast implant illness. The symptoms, the constellation of symptoms that affect the 14 organ systems of the body, that one way, shape, or another, maybe none in some patients, maybe a small subset. Young patients with almost all the check boxes, where you have complaints of silicone toxicity and how their body is overreacting to this silica that is slowly migrating into the periphery or contained, or the body is reacting to as what is a foreign body giant cell reaction. And because they do not want to accept this and call it an ICD-10 code, now they don't have to deal with it. So I say to these doctors, to these surgeons, is Danica Kirkpatrick making up her symptoms so that she can get more popularity? Are all my patients who are benefiting well over 90%, are they all making this up so they can get more Instagram views or TikTok views, and they can be now happy and accepting? Are they spending all this money to get a proper explant so that they could go back to their lives and say, we did the surgery because it's popular on YouTube? No, they're getting their life back. You do not even need to talk to the patients. You will see their patients' faces before and after. So if a patient takes a picture before explant and after, a day later, a week later, 3 months later, you will see the inflammation on her face go away. Did the 1992 ban that occurred, did that occur out of accident? No, it's the same problem. And unfortunately, I say this to you, the power is in the hands of those people who determine what's safe or not. And unfortunately, the power is given in the wrong hands. And as you will see, the women are now empowering themselves, going on social media, TikTok, YouTube, Facebook, and now discussing amongst each other what is better and right for them, overriding their own plastic surgeons who do not want to even hear the word breast implant unless, and now making this active medical decision as to the detrimental effect of the implant. And I use the word how shameful that the medical community is not listening to the patients, because history is essentially repeating itself. If, for example, the social media did not exist, this would be at a very slow pace. And then we would have to rely on Oprah Winfrey shows and whatnot, all those other talk shows during the daytime. So now we could bring forth what is a real problem. Now we have the upper hand, if you will, where the patients are talking. Remember, this is a movement by the ladies for the ladies to empower themselves and say, we are smarter than these plastic surgeons who accept not what is breast implant illness, because it truly does exist. How many patients have I talked to? And I talk to every day. They say 100% they have breast implant illness, 90% they have breast implant illness, despite them going to their primary care doctor who tells them your labs are normal, your imaging is normal, your MRI is normal, and the patients know better that their body is hurting and suffering because they can relate to the other patient who had an explant and these were the same symptoms and they basically benefit and improve in the same way. The momentum is already set up, and this is what I told, the tsunami of patients are coming forth, and they are coming forth with a vengeance, and it is only going to be unavoidable that this ban is going to occur on the silicone implants, and certainly hopefully this time around on saline implants, and that this cannot be stopped because you cannot stop the truth. So breast implant illness is a real entity, a real problem, and guess what? I'm going to read the next line. It says, some patients report complete resolution of symptoms. Complete resolution means cure of symptoms when the implants are removed without replacement. And so this is where they're telling you there's a cure. If someone denies that the earth is flat or round, personally speaking, I could care less, because we already know that the earth is round. There is no credibility to a primary care doctor who says, I don't believe in breast implant illness, because this primary care doctor may not have even touched a breast implant in his career or in his life. And you cannot ask me to read an EKG or echocardiogram and comment on a patient's well-being. And likewise, or if I were to take care of a pediatric patient, I'm not a pediatrician, I'm not a radiation oncologist. Me to weigh in on a rheumatological lupus issue is essentially, I'm as good as the layperson, because I am a board certified plastic surgeon. My specialty is on implants. And if you put the two and two together, you will inevitably reach the conclusion breast implant illness is real. It cannot be disregarded. It's not present in everyone, but one needs to understand they're not lifetime devices.
I am 11 days post-op, and my surgeon said he was not able to pull 1 centimeter of muscle down because it was all scarred in. Is there a way to see if my muscles are in proper place where they should be, and if something more could be done to improve muscle function and also aesthetics?
So this is a very heavy-ended question. Now, remember, once the muscle is cut, it retracts, contracts. So let's say I, use the example of, say, the Achilles tendon. If I were to cut it, you will see the whole muscle will retract up into the upper part of the lower leg. Maybe an hour or two later, you could connect it, but 3 months, 6 months, a year later, you cannot take that muscle that is retracted up and move it down all the way. So if a young lady or old lady, for example, in her 50s, 60s, she has the muscle cut, the pectoralis major muscle cut, the muscle retracts up. You cannot take that muscle a year or 2 or 3 later and bring it down to where it was because it has contracted. Very similar to someone who has a knee contracture, where the knee is literally bent inward and basically flexed. And now a patient who is stroked out, for example, you cannot take that leg 6 months later, a year later, and straighten it out. And sometimes it is impossible to do that. And so likewise, in that case where the muscle was cut, it has retracted up. The surgeon, depending on how the initial surgeon did the surgery, you cannot take that muscle and basically anchor it down to where it once was, because it is virtually impossible. It's like taking an ice cube, throwing it in the swimming pool, and 10 minutes later saying, I'm going to bring that ice cube back, because you cannot move that muscle down because it has been cut, it has lost its purpose. Now, there are some extremely smart plastic surgeons who have done the surgery right to begin with. The patient, my Hawaii patient from 8 weeks ago, her surgeon was super smart, did the right surgery, did not cut the muscle on this young lady, and snuck in the implant underneath, because it was a reasonably small implant, and I dissected the whole implant and capsule out underneath the muscle without the muscle being cut initially or by me. And now I did not have to quote unquote repair the muscle. The many other surgeons who cut up and down, they inevitably have to sometimes cut through the muscle, and now they have to repair it. So this is where their muscle repair comes in. I myself, I'm always below the muscle, so I do not need to repair. Sometimes the muscle is so tightly adherent to an atrophied, let's say on a 70-year-old, where remember all these years that the implant was below the muscle is not used. Because if the patient starts using the muscle, they're going to press the implant against the rib, and it's going to be an awkward feeling. And the muscle atrophies, it diminishes over time. And now, because of the atrophy, that muscle truly was not used. That muscle cannot be brought down. In those patients where the patient was like 5 feet 11 and 200 cc implant, that muscle absolutely can be repaired. I repair the muscle all the time whenever I can, so that the patient has not only function but also aesthetics, because it certainly does add overall to the aesthetics. In the vast majority of the patients, the muscle cannot be pulled down to where it once was. Now remember, all these years, if you have an implant below the muscle, you truly are not using your muscle. That's why the bodybuilders get the implants above. Athletic patients who are very much into working out get their implants above. That's a problem in itself, but the majority of the times where the implant is below, once the muscle is cut, it's lost its function, and you never truly use that muscle effectively to begin with. Imagine you are like an Olympian and you are a runner. If I put the implant below your thigh muscles, do I expect you to do that 100-meter sprint dash in the same manner? Absolutely not. You're going to press against the femur, and it's going to be an awkward feeling where the implant's going to move up and down. Now, with the implant gone from the chest, I tell my patients at the 6-week mark, they get 2-pound weights and not only flex and build up on the pec major, which they truly were not using, but the pec minor, the latissimus, the deltoid, the serratus anterior, the suprainfraspinatus on the back, the trapezium, the neck, back, shoulder muscles, and now they will be better than ever before, and they will be able to function very effectively. Their posture is going to change for the better. The inflammation that the implants are bringing to the periphery is going to be gone, and you're going to see the secondary effect, or the capsular contracture. Overall, the improvement is going to be for the better, and you're not going to miss the muscle, because all these years that you had the implant, you truly were not missing the muscle. And again, a lot is dependent on how your initial surgeon did. If it's off by a centimeter, you cannot take a suture and anchor it down, and the next thing you know, if you flex a little, you're going to tear through the muscle and cause bleeding. So the surgeon has to be very, I use the word smart, determined, and if the muscle can be repaired, it can be and must be done so as to allow for aesthetics. Now, on another group of patients, which are the cancer patients, if you have the muscle is cut and a tissue expander is put underneath the muscle. And then every month the patient and then they close the muscle. So it was a small slit in the muscle that was made, and the tissue expander was placed below the muscle. Now the patient goes every month to the plastic surgeon, and they put in like 50, 100, 150 cc's, and they expand that tissue expander. So that 4 or 5 months later, now it's up to 600, and then they remove the tissue expander and replace with the silicone or the saline implant. And now the muscle, as I remove that saline or silicone implant, I cut, make the slit, remove the entire implant and the capsule, and then I repair the muscle. And I've done this plenty of times because the surgeon did a very good job in a very systematic, calculated stage fashion. In those patients where the alloderm was used and the muscle was cut and the alloderm is covering the lower one half or one third, that muscle cannot be brought down. And so that muscle repair cannot be done. And not only by me, but anyone else. Because the damage was done, it was a permanent damage. Once the muscle is cut, it is a permanent loss depending on how the surgeon cut it.
Can 1-year-old breast implants cause scoliosis, difficulty breathing, or cause the thoracic spine to press on organs?
So remember, so if you have an implant sitting on the chest and there's capsular contracture, the implant themselves, if you do your readings, you will see will cause a concavity effect on the ribs. Some more, some less, depending on how big they are, how they were placed, and how they sit on the chest. So you will see there in the normal patient, the ribs are up and out. You will see they will start to kind of take and have a concavity where they bend inward. With the implants gone, they will expand out because remember the bone is always remodeling. They say the entire skeleton kind of replaces itself 6 months, 8 months later, depending on the physiology of the calcium phosphate and then the other hormones of the bone mineral health. The other thing here is the effect of, what was the first part of the question?
Do 1-year-old breast implants cause scoliosis, difficulty breathing, or thoracic spine to press on organs?
Yeah, so remember the scoliosis, there are millions of people who have had implants and they don't have scoliosis. So scoliosis might be and is independent. Now, if you have an implant that's sitting on the chest, I will tell you, this was a study that was done. They said everyone has, if you put the weight of the implant on the chest, if it's a young patient, initially they might be able to hold it, but because of the sheer weight of the implant, they have some sort of maybe even 1% of the weight of the implant that's going to cause the chest to kind of fall out, move forward. Just like a pregnant patient, when she walks, she's kind of balancing herself such that she's balancing her body as she walks. Similarly, likewise, even to a very small degree or to an exaggerated degree, you will see the weight of the implant is going to cause the patient to kind of shift forward or hunch forward, just like you have patients who have large breasts. Remember, if you carry the implant in your hand, you might be like, oh, it's not much, it's only 325 cc's. After a minute, you might be, well, it's starting to get heavy. After 3 minutes, you will drop the implant and see your back overall adapts to that weight. Some less, some more, some to a very minimal extent, but it will affect negatively. So I have had my patients who said that once the implants were removed, perfect example is the 89-year-old patient I operated on. She had the large implants, and her daughter and the patient said before she was walking with her chest falling forward, and now she's able to sit up straight because now that the implants are gone. Also, the other thing I must mention is when the patients take a nice deep breath, this is a patient without implants, the rib cage goes up and out. So it basically expands out and up. And when they exhale, the ribs basically narrow together and they exhale. So the whole chest goes inward and smaller. When you have a capsular contracture where the entire implant is sitting super glued, super tight with a capsular contracture right on the chest, now the patient wants to take a nice deep breath. You will see the expansion of the ribs is not going to be as free because now you have that contracture, you have that scar tissue that's holding the ribs together, and that truly limits not only the rib movement, in some patients their shoulder arm movement because everything is super tightly congested on the chest. So these patients certainly seek benefit not only of the posture but ability to take a nice deep breath with just the weight of the implant, if you will, the sandbag, if you will, the silicone gone. You'll see that the patient's improved with the inflammation gone. You're gonna see that the patient's gonna improve upon her ability to take a nice deep breath.
Are many surgeons capable of doing explants properly, and do you disagree with having fat transfer to the breast?
So I will tell you, my acquaintance friends, plastic surgeons, my close friends who are plastic surgeons that I know, my colleagues that I have been operating with and they come into the room to see what I'm doing. It's not uncommon to do that at the hospital. When they see what I do, another way to look at it, if you ask 100 plastic surgeons to do an explant in the manner that I do, where you're dissecting right on top of the rib, removing the whole capsule, majority of them have this block that it is too hard, too involved, too risky, too long, and too invasive to do. This is echoed by the Board of Plastic Surgery in the Europe, in Canada, and by the US, that it is too expensive, too invasive, not justifiable, not worth the risk. I will tell you, if a patient has a ruptured implant, the end block, where an entire implant capsule is to be removed in the fashion that you have seen in the many Facebook, YouTube lives, that needs to be done in that manner. And I've said this many times, 20 years from now, I cannot imagine anyone else doing the surgery any differently, because if you do any differently, the silicone is going to spill into the chest, and then now it's a lost cause. How can you clean out that silicone from the chest? Because you cannot. Once it sticks into and basically embeds within the soft tissue, it will linger on. So going back to the point, if I ask 100 plastic surgeons, can you do it all the time? They will say no, because they feel uncomfortable. They're not sold on the fact that they need to do this, because they truly in their heart and soul are still augmenting. In their mind and soul, they're still not firm believers in what is breast implant, unless they are the fact that if it's a ruptured implant, that the entire capsule must be removed. They do not even believe that the capsule needs to be removed. Some of the patients have gone to the many surgeons who say, well, let me see what happens in the OR, in the operating room. If the capsule is small and thin, I'm going to leave that behind. If I can remove it, then I will remove it. And so it's like kind of case by case basis. No, as I have said many times, the 100-100-0 rule, 100% of the time, 100% of the capsule is removed, with 0% of the capsule remaining behind. And it is, number one, a firm, absolute commitment decision in the surgeon's mind that BII ruptures occur, inflamed tissue, silicone spills into the periphery, that this must be done. Breast implant illness does exist. There's silicone toxicity that occurs, there's spillage. And number two, that the surgeon is able to physically carry out the operation, and that the surgeon must show high definition pictures and videos of the chest wall showing complete removal of the capsule, period. Case closed. So it is a big task. And remember, as simple as it sounds, removing the whole capsule, that is the whole surgery. Let me give you another analogy. If someone has a pancreatic cancer or pancreatic mass or a lung mass, for example, and there's cancer, are you going to say, well, it's too invasive, I'm not going to do it? No, you have to do it because that's the right surgery, right? Yes, there are risks involved, but guess what? In a very calculated way, remember, this is still outpatient surgery. It can be systematically, thoughtfully done, and it must be done because that's what ensures. 3 patients within the last year and a half had CD30 positive. Remember, that's a risk factor for lymphoma. Those patients did not have to come back for kind of completion surgery to remove the capsule, or I did not cauterize the capsule on the rib and saying, well, if it comes back, then I'll come back. No, she got the surgery right then the first time definitively. There are so many patients who have had incomplete, partial removal of the capsule, and they themselves did not get better, did not feel better. And now they came to me for a residual capsulectomy. Then only did they improve. You do not want to be in this category of patients. I talked to a patient on Friday. This was, 4 days ago, 5 days ago, and she had her 36-minute explant. And you can see clearly the capsule was left behind. She's not improving. There was another patient, who went to another local plastic surgeon, and she herself removed the implant. She documented the capsule was removed. Post-op, the patient did not improve. She knew subjectively as a patient that her surgeon did not do the complete surgery thoroughly, completely, definitively. Then she went to another plastic surgeon who did an exploration of the chest, only to conclude that there was residual capsule, and that what was claimed to be a muscle repair was never done. And this was clearly the patient herself knowing in her heart, mind, and soul that initial surgery was not done by the surgeon. Because if you ask me, that surgeon did not know how to do it, even though she was a firm believer in what is breast implant illness. And the point goes to showing you this is a surgery that is relatively very hard. I had another very seasoned, experienced 35-year-old veteran surgeon, plastic surgeon, who came into my room and he saw how I was dissecting off of the rib. And he said, I do not want to do that. I do not want to think about doing that because I don't want to be involved in that type of a meticulous surgery. And this is how it takes, and this is the commitment into doing the surgery. Even if I were to hire another plastic surgeon to come in and help me with my many patients who come to me from far away, and if I were to teach him, I personally believe from my heart that he will not be able to reproduce how I'm doing it because of the learning curve, about the commitment, how to doing it with the minimal blood loss. There will be a learning curve as well. But as you will see, this is on-the-job training for all of us, including me. No one taught me this in my training. I kind of put the two and two together. I saw how the surgeons, and ultimately by looking at the many pathology reports, if you will, that I did, these are the pathology reports, and I saw, synovial-like metaplasia of the wall of the surrounding capsule, focal histiocytic reaction to non-polarizable material consistent with silica. That silica was within the capsule. This is the final pathology report, and that this surgery is done correctly, first time, complete, and this is how I do it as the con procedure, that the entire capsule is completely, sincerely, definitively removed, along with the inflamed tissue and the implant as en bloc or 100% total capsulectomy. That is the goal of the surgery. In my experience, I find 80% of the patients do not need the unnecessary lift. I do not use drains pretty much in any of my patients. Last time I used this was almost 5.5 years ago. The implants are always returned to the patient. Capsules are always sent to pathology to rule out that rare BILCL. Cultures are done for bacteria and fungus, aerobic, anaerobic, and fungal. High definition pictures and videos of the chest wall showing complete removal of the capsule. Twilight deep sedation, so the patients are not paralyzed, they're still able to breathe, they have no recollection of the surgery, and regardless of the comorbidities or the underlying medical problems that the patients have, they will get the same surgery. The 89-year-old got the same surgery as a 22-year-old. This morning I talked to a patient who just last month in July of 2021 had an ischemic stroke. She is going to be getting her surgery done at the hospital in the same manner. I need a neurology clearance. I need at least 6 months, a year to go by before I can even operate on her. Remember, this is elective, semi-elective surgery, and there is no rushing into the surgery. Every case is if you will, a very involved case. And this is where I myself go through the screening protocol, making sure, having talked to all the patients, remember 9 out of my patients out of 10, that is 80 to 90% of my patients come to me from out of town, and that I initially screen them on the phone, and then I have their primary care doctor and neurologist, in this case, for example, will give me feedback, and then I have another consult with them to determine if I'm going to even operate on them to begin with. And so there are a lot of factors that I have. I review my charts independently of my anesthesia team members, be it the MD or the CRNA and the nurse, so that the three of us are going through check and balance. At any given time of the week, I only do 6 of these, 2 per day, sometimes even 3, depending on the cases, such that the patients get 100% out of me and my system and my staff. And I treat everyone as if they're the president of the US, so that complete utmost care and a lot of work into preparing for the surgery.
Is SIIS, silicone implant incompatibility syndrome, applicable with saline implants?
Yes, remember the saline implants have that silicone shell. That silicone shell is enough to impart all the problems that we know of intact silicone implants, ruptured silicone implants, and that is the ultimate underlying root cause of the problem. The body is recognizing that silicone is foreign, it's reacting negatively. It is basically the foreign body's reaction, not again in everyone, but eventually this will be an issue. Remember, implants are not lifetime devices. If you go back to the black box warning, and I'll read this again, breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery, quote unquote. And so the bottom line here is it is similar to, and as I mentioned earlier, patients with saline implants, intact saline, ruptured saline, intact silicone, ruptured silicone, textured silicone, textured saline. All these patients have interchangeable, similar complaints, similar problems. Some, none at all. Eventually they will, because they remember they're not lifetime devices. And that on average, the implant lifespan is 10-15 years. Anecdotally, if you ask me, 7 to 10 years before they start becoming reactive.
Is it standard to have a full lab workup prior to surgery?
So this is very good question. So I tell my patients who I've not met majority of the times because they're coming from out of state, that you go to your doctor to make sure you have a normal iron level, so that people who have low iron are basically usually anemic, weak, lethargic. So you want to address that. You do not want to be getting surgery if your iron is low. B12 level is low. Your basically your potassium is off, for example. Your thyroid levels have to be checked, because if your TSH is very high, then you are low thyroid. That means you're hypothyroid, and you might be making symptoms of what is breast implant illness. So that fatigue might be a result of that. Now, the bottom line here is, once you have, remember, they are not infinite number of labs. They're just like 20-30 labs that need to be done. That tells me, as you come to me, you have no underlying problem. So one patient that I talked to from California, like a few years ago, she told me my labs are all normal except for my ALK phos and AST and ALT are high. And I said, why is that the case? And they're like double and triple the upper limits of normal. And I told her, go to your primary, go to your hepatologist. You need to rule out something, there's a problem. The most common cause of elevated liver function enzymes in the US is basically a fatty liver. But I could tell just by, and this was just a phone consultation, patients all the way in California. She went to her doc, and believe it or not, her primary care doctor did a whole series of workup for the liver, and it turned out that she had hepatitis C. She went and got treated for hep C, was put on the meds, and then she came to me for the explant, and her doc was, again, working her up to make sure all her numbers are good. Now remember, regardless of the surgery, your numbers should be good to begin with. And the bottom line here is, those patients that are on a lot of supplements. So one patient came to me, she had a bag of 20 supplements. She got her labs, and it turned out that the potassium was 5.5, and it turned out that one of the chemicals, i.e. whatever she was taking in that functional medicine doctor prescription, was high in potassium. Remember, these supplements are not even regulated by the FDA. I could make a supplement in my backyard and sell it tomorrow to the patient, and they will know what is in it. And this is unfortunately happening a lot. So this is where this patient came off the medication, and it turned out her potassium normalized, and that was the underlying culprit. They themselves tell you, people who market these functional medicine tablets and chewables or whatever you call them, that we do not know what's the true ingredient, because they're not regulated like the thyroid medications and levothyroxine, that's 112 micrograms, for example. So the bottom line here is a set of labs, very important, so that I don't need to see the labs, but this is when your primary care doctor says your labs are good. That means I have the peace of mind that the doctor is telling me all those labs are good, and that you're in good shape and optimized and ready for surgery. A patient had a TSH of 12. I said, I'm not going to operate on you, because that can cause arrhythmias on the operating room table. It has to be below 5 and above 0.5, and so it has to be within the normal range for the patient's own good, regardless of the surgery, but certainly for the surgery as well. Some patients, if you will, report that the ANA is positive, but they went to the rheumatologist and everything is normal. You can certainly get the surgery even if your ANA is negative, because regardless of the indication, what the labs show. Remember, there is no lab test, no imaging test, even a inflammation marker like CRP or ESR that will tell you if you have breast implant illness or not. And so the bottom line is, there is no lab test, no imaging test to show, but this is, as you come to me, I know you are healthy and there is nothing that is causing the problem.
Do all implants have a microchip in them?
No. Having said this, there was an implant that I removed, the independent, last year, micro-textured implant, and there was a metal chip on the inside. And so this is newer technology. But the older set of implants that have existed, the Mentor and the Trell, amongst others, they do not have any metal chip in them. This was indeed like a metal chip that I saw that was within this newer generation implant. And this is what they were trying to use to kind of study, gauge. Again, I do not know. I looked it up. I read up on this. It is basically for long-term follow-up as to what the implications are for that chip to be inside the implant.
What is the best diagnostic test to detect a ruptured implant?
So the only test that exists in 2025 that tells you if you have a ruptured implant or not is an MRI without contrast. Ultrasound, technician dependent, better than nothing. It is not an optimal screening tool. Remember, any test that's done, it has false negatives and false positives. Even the MRI is not the perfect test, but an MRI without contrast, no radiation, magnetic resonance imaging is the ultimate test of choice, as mentioned right here. MRI without contrast to look for what is a rupture, where you'll see a Linguini sign within that shows that there is a rupture. Remember, in my practice, there have been cases where the MRI was done and it showed intact implant on the right and left, and I go for surgery and it was a ruptured implant on the right. So the MRI was wrong. And conversely, there was another case that I did, interestingly, on the same day where the MRI said that the implant was ruptured. I go in and the implant is intact and there was just fluid around and the read was incorrect. Remember, no CT scan, no mammogram, no ultrasound, none of these tests will pick up with good sensitivity and specificity that the implant is ruptured or not. Ultimately, the MRI is the ultimate is when you go for surgery, and this is why I assume that the implants are always ruptured to prune otherwise, because there might be a small amount of fluid. I only mandate an MRI in those patients where they had a first set where the implant was ruptured, silicone free floating, and then they got a second set, so that when I remove the second set that is intact, I also remove the free floating silicone that may have harbored pockets that might have been walled off when the surgeon was suturing. So I want to pick up on those silicone granulomas, silicone spilled tissue that might be hiding in the pockets, that an MRI will help me. I look at a surgery where in this case, it's like a Navy SEAL mission. You come down from the helicopter, you go into the compound, into that room, in and out without, quote, goofing around. In the similar case, if a patient has had a ruptured implant from her first set and her second set is intact, I want to remove the implant capsule from the second set, and that spilled residual silicone or capsule, whatever scar tissue that feels abnormal, looks abnormal, palpates abnormal, my gut sense is abnormal, so that the patient gets the best out of the surgery.
I was diagnosed with a brain tumor last year. I am convinced it is from the toxins and chronic inflammation caused by my implants. Do you think this could be the cause?
So this is a good question. There are almost 35 million people on earth who have implants, who have had implants. And I will tell you how many brain tumors that we see. Now, there is no correlation effect between the implants and someone getting Hashimoto's, someone getting a brain cancer, for example. Now, I, as a plastic surgeon, from what I have seen and read and heard, I do not believe that is the cause and effect. Now, going back to this phenomenon of what is autoimmune diseases, right? Remember, the women are more likely to get autoimmune problems than the males. And as you will see, let's go ahead and read. Patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. Autoimmune disease is like a very broad spectrum of whatever autoimmune problem there is. Now, they're telling you there's complete resolution when the implant's removed. Now, clearly there is an autoimmune problem, because what is the underlying problem? There is a silicone, there is leaching of the silicone, there is reactivity of the body recognizing the implant as foreign, and now there is the immune system's on overdrive, goes haywire, and starts kind of overreacting, inflammation response. And this is the root cause, underlying cause of the problem. Now, once you have this autoimmune problem that they're telling you, right, is occurring, how much, in what capacity are these other autoimmune problems that are associated? So the bottom line here is there is an association, we do not know. So as you will see, look at the MD Anderson study out of MD Anderson, Dr. Clemens, who is the chief of plastic surgery, who studied 100,000 patients who had implants, 80,000 with silicone, 20,000 with saline. And this is a study of studies, it had its drawbacks, but they concluded that if you had implants, be it silicone or saline, you had a much higher chance of getting Sjogren's syndromes, dryness of the eyes, scleroderma, which is a connective tissue disorder, rheumatoid arthritis. The bottom line here is there is cross-reactivity, reactivity, immunologic hyper-response, and there is an autoimmune response. And this is, they're telling you, quote, some patients report complete resolution of symptoms when the implants are removed without replacement. So they're telling you have resolution of these autoimmune problems because the body's immune system is not relaxing, it's not on overdrive, and the bottom line is there's improvement. So in summary, this breast implant did not cause the for brain cancer because you have millions of others who did not report. You have millions of others who have reported that they got breast implant illness, autoimmune phenomenon, right? As you will see in my checklist, if you come to me or you do a phone consultation, you will see the list of problems that you can have, anywhere from dry eyes to anxiety, panic attacks, ringing in the ears, swelling around the eyes. But down here, common autoimmune symptoms or diagnoses like rheumatoid arthritis, lupus, Sjogren's, Raynaud's phenomenon, Graves' disease, Hashimoto's, scleroderma, multiple sclerosis, ulcerative colitis, Crohn's disease. This is where, we do not know if you are going to get it or predisposed to it, if there's a genetic component or if it's the implants. The bottom line is you remove the implants to remove them out of the equation. Will someone who gets implants will be more likely, according to this study, they're reporting yes. Is there someone who got Hashimoto's from the implants? I say no, because there is no direct correlation. Do you have a higher chance? According to the studies, yes. And they're telling you the autoimmune problem. So if someone asks me, did my implant give me Hashimoto's? I will say there's no convincing evidence it did. And that there are millions of other people who have implants and they do not have Hashimoto's.
Why do we want our implants returned to us after explant surgery?
So this is a very good point, and I make it a point to return the implants. What is interesting is I removed the implants and the patient, and this has happened too many times, 15-20% of the times it happens, where the patient said, you gave me saline implants back and I paid for silicone, or vice versa. Just recently, a nurse, very well read, she was very systematic and thoughtful. She said, I paid for silicone and I returned saline implants to her. And she was very upset. And another patient, she said, I wanted the saline implants and I got silicone implants that were put in her body. Another lady that I did a few years ago, she had the lot number on the implant that was imprinted was not the same as her card. Another patient had silicone on one side, saline on the other. Another patient had Allergan on one side and Mentor on the other. One patient had implants above the muscle on this side, below the muscle on that side. Another patient had like a McGann, which one type implant and Mentor on another. And the point here is I want to be able to tell the patient that this is what I removed. Number two, so there is mental psychological closure. And number three, more importantly, that the saline implant was not ruptured on the way out. Another patient went to another surgeon and she told me her surgeon ruptured the implant, pulled out the deflated implant, and then removed the capsule. That is not the right way of doing it. And so you want to see that the surgery was done right, that the implant was removed intact along with the implant capsule and what is the en bloc fashion, and not damaged on its way out.
Okay, two more questions, Dr. Khan. I am having squamous cell carcinoma removed next week and have silicone implants. The doctor refuses to acknowledge that the implants have anything to do with the cancer. Could my implants have caused this?
So this is a very good question. As you will see, a few years ago, the FDA put out a warning where they said that the breast implants themselves were associated with what is BIA-SCC. Breast implant associated BIA-SCC squamous cell cancer. That is the capsule tissue around the implant. I was surprised to see that that was the case. Now remember, the FDA and the Plastic Surgery Societies say two things definitively. There is no discussion here that the number of cases of BIA-LCL, BIA-SCC are underreported. The reason behind that is many surgeons are not even removing the capsules. They do not believe in removing the capsules. They're not fixated in removing the capsules. Even when they remove the capsules, they're not sending it off to pathology. Even when they send it to pathology, they're not doing the CD30 analysis, or they're not looking out for the badness. And so it is undermissed. So that is a firm fact that no one will deny, and it remains undisputed. So that is underreported. And number two, it is not the BIA-LCL or the BIA-SCC squamous cell cancer. There are many other types of cancers that are associated with the implants themselves that we have yet to learn more about. The T-cell lymphoma, the variations of the T-cell lymphoma, because remember, this is an inflammatory response. And the body's on overdrive, and now the immune system goes haywire, and now you have these, quote, reactionary lymphomas that are occurring. Now, the bottom line here is, if someone gets skin cancer, that is, if you ask me, from what I know, and it's limited knowledge that we know, that this is basically not a direct correlation between the patient getting implants and then skin cancer, squamous cell cancer on the skin. It might be because she's Caucasian and a lot of sun exposure, right? So there is no correlation. Now, what's interesting is if you look at the MD Anderson cancer study, the 100,000 patients, Dr. Clements, very notable figure in the world of medicine and plastic surgery in the world. It's not a small hospital in the middle of Michigan or Texas that put out the study. This is a major hospital, and they did the studies very well. 100,000 patients. It's a study of studies. It's not like the prospective cohort randomized trial. That would be the ultimate test, right? They concluded there was a high chance for so of the 100,000 patients they studied, this concluded in the observation that there was a higher, there were a lot of patients, there was a higher number of patients who had melanoma compared to the general population, which I find very interesting. And this is, remember, not reported by me, this is in the study. And so this was very odd that this was the case. It was higher in those patients who had implants compared to the patients who did not have implants. And so remember, there's a lot more research that has to be done. But as just like with the Hashimoto's, if you have implants, there are millions of people who have implants who do not have a higher chance or high incidence of squamous cancer. I do not believe there is a correlation between implants and getting skin cancer, but there is a direct relationship according to the FDA that you will get squamous cell cancer in the capsular tissue around the implant. Now, let me tell you this, in the world of burns, for example, you have a patient with a chronic burn and use the word, a patient who had a burn long time ago, 5-10 years ago, and you can read up on this marginal ulcer. So a patient had a burn long time ago. Let me give you a perfect example. Back in the day when you had garbage, you would go out in the backyard and you would burn your garbage before, So one patient came to me in my burn/wound clinic when I was in my training, and this was an elderly gentleman. He had a burn on his leg, and he said, I have a wound that's not healing. It was a burn from a long time ago. This is squamous cell cancer, marginal ulcer till proven otherwise. And lo and behold, we did the biopsy, and it was squamous cell cancer because there was a chronic inflammation, a chronic wound because of a burn long time ago. And this can occur. So if you have, and again, this is just me kind of knowing what we know, there is an inflamed state. It's a wound that's healing chronic inflammation. Now you have reactivity that's occurring. Overall, the point here is BIA SCC is real. It's been brought to my attention by the FDA, and it's a real entity, and it is breast implant associated. Had the patient not had the breast implants, that squamous cell cancer around would not have formed. The skin cancer is a different issue, and it's not related, if you ask me. And more research analysis needs to be done to be able to conclude that there is a direct correlation.
I had a total toxicity test done after explant. Heavy metal and chemical burdens still were present. I did a full body detox and was retested, and there was significant improvement. What are your thoughts?
So let me just mention this. There is this whole detox protocol that you hear about, that I went and got like a multivitamin drip while I was getting my surgery, or that I enlisted with this doc, functional medicine, who did a detox protocol here, 1, detox protocol 2, very expensive. I will tell you, this is not real science. This is not real medicine. I talked to a patient last week. Her husband was a nephrologist, a kidney doctor, and remember, this is the doctor who's responsible for dialysis. If you want to clean out the blood, you have to do something like plasmapheresis, or you have to have like a true chelating agent that's going to take all these heavy metals, and they are going to basically get rid of the body. So someone taking these cleansers, if you will, detox agents, in my mind and eyes, is pure utter garbage. And this is echoed by vast majority of the doctors, that there is no validity to them, that sometimes they cause more harm than hurt. If someone takes a whole bottle of charcoal to cleanse their body of toxins, that is wrong voodoo medicine. If someone ingests like 20 aspirins to commit suicide, yes, you give charcoal to them in the emergency room setting, the charcoal binds to the toxic agent, and then the person basically removes it as feces, or they cough it out, if you will, they vomit it out. The ultimate and detox is the surgeon removing the whole implant, capsule, and all inflamed tissue completely, sincerely, definitively, wholeheartedly. So now you do not have to go through the detox protocol. Now, sometimes, as you saw me read, that the silicone spills under the periphery, it gel bleeds, it lands in the lymph nodes. Removing lymph nodes is not the answer, because now you're going to get lymphedema, other problems. It may have spread to the liver and other areas. There is no chelating agent. There is nothing that's going to extract the silicone out of the system and basically remove the heavy metals from the body. There is no validity to it. You could get heavy metal from lead poisoning and Flint, or you live in the Gulf and you eat a lot of seafood. You could be getting a lot of heavy metal from that. Now, I'm not an expert in this, but I know this much for a fact, that you're not going to take something by mouth and all of a sudden the body is going to self get rid of the silicone and the silicone toxicity and the heavy metals. This is, even if the toxicologist will show you, the Dr. Atul Mehta out of the Cleveland Clinic, he had a patient with saline implants, and he found silicone within the lung tissue. And when I asked him how did it get there, he said the bloodstream. And remember, it's deposited into other parts of the body. If you look at Dr. Henry Dyckman's study, where he did a biopsy of the different tissues of a patient who had a ruptured implant, he found different densities of silica deposited within the tissues of the body. And the bottom line here is that no, and I believe this, and I know this to be true. If I was not sure, I would say I do not know. No detoxing agent is going to take this and chelate and free and minus the body of this toxins. Ultimately, the only and one way is where the entire implant capsule is removed, so that there is no toxic burden left behind. And the body in itself, once this burden is removed, you will see the majority of the patients improve and benefit over time as the body in itself heals with the toxic burden removed.
Thank you, Dr. Khan, for answering everyone's questions today, and thank you for everyone who joined us on the live today, and we will be back soon.
Yes, please continue to ask any questions. Please continue to network and talk. This is a real problem with a real solution. There are a lot of questions that have not been answered that we're looking forward to. I will end with this. We were collectively talking with a group of plastic surgeons, from different parts of the US and in Europe about what is the underlying cause or the problem. Why is this even occurring? I said, we don't care whatever the problem or the mechanism or the reactivity is, whatever is this protein or this problem that is, we know these are bad. They should not be put in the body. They should be taken out before a bigger fire occurs. You do not want to wait for a rupture and then take it out, because now there's possibly more damage. If someone has implants that are old, that in itself alone is a reason. If someone has questionable rheumatoid arthritis or not, remove them, because you remove that out of the equation. We know this is the silicone cross-reactivity because we have what are the pathology reports. This is, not in every patient, but you'll see foreign body giant cell reaction, focal histiocytic reaction. We know that the ban occurred. We know the many patients who have improved. I said in the United States, there are 400,000 patients plus minus who augment, who get implants, be it saline or silicone, for cancer reasons, cosmetic reasons. Eventually, sooner or later, plus minus 10 years, they will all need to get them removed, replaced. You do not want to go through this potential very, very, very small risk of getting that lymphoma or the squamous cell. The risk of rupture. Look, last week I did a case where 4 years into her augmentation, this patient ended up getting a rupture on the right side. She had implants put in. Do you want to be that patient 4 years into that you get a rupture? Another patient got capsular contracture 6 months after. Do you want to be that patient? Eventually, there's only badness related to the implant. Sooner or later. Later means plus minus 10 years. And remember, they will tell you that they are lifetime devices, which is wrong information, incorrect. They are not lifetime devices, as you read. Do no harm, understand this problem. If you have implants, know what you signed up for. Many of the patients, 90% or more, do not even understand what are the implications of getting implants. If you ask me, having talked to thousands of patients, you need to educate yourself about what is the potential hurt, what are the problems, complications. On my next Facebook Live, I will just talk about and list all the problems that the patients go through who have implants. Ultimately, the patients have said two things, and I'll end with this. The patients that I've managed, they say they wish they had never gotten implants, number one, and number two, they wish they had removed them sooner so that they would not have had to deal with this problem eventually, because it's all inevitably going to happen. It's like, I do not want to be dramatic, or it's like you playing musical chairs. There will come a time where your time will be up. And you want to be smart about it and not take chances. This is Dr. Khan, Executive Plastic Surgery.